you, Penny. Questions from the committee? Oh, let me give one caveat. We'll be cutting this session short by about 5 minutes, so about 10 minutes to, or 5 minutes to 3 works well for you? Okay.
In your survey, did you try to correlate any types of pain with, I know you didn't ask about specific medicines, but did you ask about type or kind of pain that your patients or the people were treating?
No,
Okay.
we did not. We do in other ones. I did not in this one. Again, you know, if I had thought more. Yeah, right, yeah. I mean, I was surprised that they responded. I was surprised how many people responded as quickly as they did. They were just really filling it out really quickly. And then after you send something like that, you think, oh, I should have, but yeah. But I'm thinking down the road, I'd like to do another survey after hearing all of this with more details, but I don't want to do it right away. I don't know how long you're.
Yeah, thank you for that. So what was the total number of people surveyed?
The number that we sent out to?
Yeah.
We have probably on our mailing list that we survey out to about 10,000 people.
Okay. And then second, you mentioned that 56% said they had trouble obtaining their medications even when they had a prescription. Is that because of cost? Did they say why? Or
No, these are probably people who take an opioid. And so I know when we did a big survey on that. We have a lot of, we actually did a video on that as well. But a lot of people, I know like one of the comments, one of the things where 7% of those people were asked to provide their complete medical records before they were allowed, before the pharmacist would actually fill their prescription. I mean, no one carries around their complete medical records. There were a lot of questions about why they need it, too much, they don't carry it anymore, especially the inner city ones don't carry it anymore, they're being afraid of being robbed. I mean, there's a lot of, so it's all around the opioid issue is where a lot of that was coming from.
okay, thank you.
Yeah.
John?
There are a couple of sides to every issue, as you know, Penny, and just let me ask, you've presented very nicely the data relative to people not being able to get it. There's also, I think, some concern that in prescribing very expensive medicines where there isn't evidence that it works, and understanding, as we were talking about just before, that there may be individuals, even if it's not demonstrated to work in a population, there may be individuals who get some benefit. I wanted to ask within your population whether you've asked or whether people have felt that these medicines or any medicines that were expensive were being prescribed and they shouldn't have been, or they didn't have evidence that it worked, or that they're being told to buy expensive medicines when they can't afford it, and they're sort of being forced in a way to use medicines that they don't feel help them.
Yeah, I think when it comes to people, especially, and if you look at this, most of these people had pain for 10 years or more, so they're not newbies to this. They're not, they just didn't get into the pain. They've been living with it, some of them for 20, 30 years. And I think when it comes to being able to control your pain to get your life back, because pain is so very controlling, that the cost is almost like whatever it takes. And so they may try it and then they'll stop it because it's cost too much. I mean, and again, if you look at the employment of a lot of these people, they've lost their jobs because they can't function, they can't do their job, or they're, the presenteeism, which, you talk about, we talk a lot about, where people go to work and but they don't work. It's like $62 billion is lost every year just on presenteeism in the workplace. So again, they're going to lose their jobs. So they don't have the money to pay for it. And if they lose their job, they don't have the insurance, and it goes on and on from there. And so that's all part of the problem too. But, I think when it comes to cost, if they have the money and they think it's going to work, they're going to pay it because they're hopeful. I mean, you try so many things that after a while, you'll do anything to get rid of the pain. But I found it interesting, and I wish I'd asked this question too, if they put it on themselves or if someone else puts it on for them, because I think that's a significant piece right there, is because being cared for. And, and the people we surveyed, how many of them were married? So probably they do get help. But how many of the people that, and again, our population is different from a lot of the underserved population, where there may be nobody else. They may have lost their family, everything. I mean, we get those calls. Those are the calls we get. We don't get them in surveys, but we get those calls. And so I wonder how many people that are living alone, that have lost everything, that are putting the cream on by themselves versus that caring person who is showing that. I mean, I think that's a huge thing right there, just knowing, and it's a validation that your pain is real, because it all goes, it's a big circle. Pain is very complex. So you guys know that, so.
Did any results surprise you? You mentioned your work with veterans, and so I'm assuming this is an adult population. Did anything particularly surprise you?
We didn't survey our veterans because when we do, I think we do this project called Vets in Pain. So I've been to 79 VAs so far in the last few years, but we're not allowed to email them, but we have them on our mail and they get our newsletter, but we're not allowed to include them in these surveys. And that's where sort of that weakness thing comes in. But I don't know that much of this surprised me, only because of the calls that we get in our office from people who are struggling with so many different things. I mean, in today's world, the pain care is almost impossible. I mean, they're being fired by their providers, and there's so many of these that are taking opioids, but they're not being tapered. They're just being shut off, period, because these providers are afraid to prescribe anymore. So you're seeing people who are, again, out on the street, and that's where you've seen the big spike in the heroin use and the street drugs, because they have no other choice.
Did any of your respondents, or have you heard through your other work, who's providing education in regards to these topical pain creams? Is it the pharmacist? Is it the provider? How are people getting educated? Is it sort of word of mouth that you should try this?
Yeah, well, perhaps maybe the internet, perhaps word of mouth, but I found it interesting when they were talking, the pharmacy, the compound pharmacists up here, that they actually go through all these things to talk to their patients about how to use it, how to store it, all those things. Because when we talked, and we've worked a couple times with APHA and we always are telling people to go to their pharmacist if they have questions about their medications. That was the first graphical tool I ever designed on how to take medications, working with APHA. And the problem is the pharmacists don't get paid for that time to talk to their patients. So they're not getting that education from the pharmacist. Maybe in the community pharmacies, but not in the chain pharmacies, because they're also under a quota that they have to fulfill. So many prescriptions, that's it. And if they don't get those done, so if they take all that time to talk to you, it's not going to happen. So I doubt seriously if they get that kind of education that they need. So now that we've done this, do we need to do a video? Because I don't like to just do a survey, but a video on topical creams and really educate people both on the topical and the compound creams. Do they really even know the difference? I mean, that's the problem. People don't know, and they don't ask questions because we're afraid to ask questions. They don't want to look stupid, so they don't ask questions, so they just take something. I mean, that's why we got all the calls from people who would get medications. They would get a prescription, they'd talk to their provider, they'd talk to their pharmacist, they'd call us and they'd ask us, why did I get this prescription? We can't answer that. We're not healthcare providers. So our thing was go back to your prescriber, which is tough. So we'd tell them to go back to the pharmacist. Unfortunately, the pharmacist, which I've learned, unless it's a community one, they don't have the time to really go back and talk to these folks. That's why we designed the tool to teach people graphically, just circle, how to take it morning, night, times a day, with food, empty stomach, things to avoid, side effects, storage and disposal. We just circled the pictures, and that way people have an understanding of how to take it. So that's the kind of education that we try to do is to make things simple for people so that they can communicate better.
Thank you, Diane.
Thank you so much. I really enjoyed your presentation. And I just have a question in general about the surveys you've done and the people you worked with. Have you worked with Medicare beneficiaries and with paying those on Medicare only or Medicare without private insurance or?
On other surveys, we've asked them.
About
We didn't,
paying.
again, we didn't ask them if they were on Medicare, what kind of
Okay.
insurance they had. Again, this was a quick survey. We didn't ask them. We should have probably asked you guys, what should we be asking, and then done the survey. But, hindsight is a great thing, But in other ones that we have asked the question, and so it's pretty well spread across, age, because we ask age, we ask the date of the birth, all those kinds of things. So we do have some of that. And it sort of follows, I think, today's patterns where you have the older adults, which are now becoming sort of the majority of the population. And so we see a lot more people on Medicare, but they also have supplemental.
Okay. Thank you.
And I can't give you the numbers off the top of my head because I don't have that survey in front of me.
You touched on a couple things. Can you talk a little bit about, you focus a lot on the survey, but tell us a little bit more about the patient with pain, role of socioeconomic status, the role of gender, role of race in regards to this, or is that a limitation of the study?
Didn't talk a lot about that. I can tell you what I know, but not from this survey. I mean, we only
Please.
got 11%. So, a lot of the people that, and everybody says it's the women, women have more pain, but surprisingly, we probably get an equal number of calls from men as we do women, which surprises me because based on all the surveys and all the data and everything we do women respond more to surveys than men? Maybe that's it, because the number of calls we get, sometimes in a day, it's all men, more so, and they're very forthcoming with what their problems are. It's quite interesting. And I think when it comes to, and Knox Todd from design, but he's an ED physician. He worked with the underserved, and I know that we declared September Pain Awareness Month back in 2002. So every year we would do another project in September, and we did one year on diversity in pain. And so we know that the underserved, the non-whites typically have more trouble getting access to care, especially for pain in the ED or anywhere else than for the white people. And I keep hearing that over and over again at meetings I've been to and other things. So there is a real disparity in care between both gender, women, and I've heard a lot about this, and there's this whole thing on women in pain where, women are definitely not taken as seriously as a man. And I have no clue why that is. Just because of gender. And I just heard, this thing about equal pay for women and men. Was it Carmela Harris just said, her thing is women are going to get the same pay as men. Why shouldn't that have always been? So none of that, none of it's logical. I think it's all prejudiced and points of view from people.
So I'm going to ask one final question, unless there's somebody else from the audience, because I know you have a plane to catch. What would you recommend for this committee? What would you like for us to know? What would you like for us to include in our report from the patient's perspective?
Okay, and that's a
patient's perspective as well as the advocacy perspective. So
Yeah.
two perspectives.
Yeah, okay, and I think that's a really good question because I've been thinking about that, listening to the things this morning, and I think that people need more education around these topical creams. They need to know the difference between a compounding cream and an over-the-counter cream and a prescription cream. What are the differences? What are the active ingredients and why those are so important? And again, this is, how do you do this? I think it goes in a video and interviewing, because I know if you write a pamphlet or a paper on it, no one's going to read. People don't read anymore. That's why we do videos and graphical tools. People don't read. But I also think it's important for providers to educate their patients around why they're prescribing this for them and the expectations. And I heard something about expectation earlier, because it's always the expectation of treatment that people begin to have unrealistic expectations and think that if I do this, it's going to give me 100% relief. and it's quite often fails. And that's where we get into this, it doesn't work, because, and everyone thinks that when something like a surgery, you should get 100%, every surgery should work and you should get 100% relief. And that's not the case either. I mean, we need to be more realistic about expectations. For most people living with pain, no matter what you do, there's still going to be some level of pain. And the good news is we can teach them to learn to live with it. That's the point. We can teach them to learn to live with it. We don't know how to do that by ourselves. I mean, I am very creative, but I had no clue how to do it. Someone had to teach me, and it was going through that pain management program, the hardest thing I've ever done in my life. That program is what taught me how to begin to learn to live with my pain and the things I needed to do, because most people are passive patients rather than active participants. And so they're looking for you to fix them. And when it comes to chronic pain, a lot of times it's something that you can manage, but you can't totally take away. So I would look at helping people understand what the expectations are of these creams, why they're being prescribed, what else they should be doing, because any one single modality isn't going to help a person live with pain. It's a combination of treatments and therapies. We have this video on our webpage about our car with 4 flat tires, and everybody wants to fill up one tire. And it's not going to get you anywhere. We need to have a combination of treatments and therapies and fill up all 4 of those in order to get them up and get them going. But the person with pain has got to be at the center of treatment. We keep talking about patient-centered care. And there was a saying, nothing about us without us. And that is where, it's always nice to know that the patient is involved in these kinds of meetings where they have a voice. But I think we need to educate them more, but in terms that they can understand. But we also need to educate the providers. And that would be my recommendation, is more education so that we understand what these are for, how to use them, and what the expectations are.
Thank you. Okay, as promised.
Okay.
Thanks.
Thank you. Thank you.
Deb.